Good evening, everyone, and welcome to the discussion on the topic of COVID-19 and the impact of it on BME women. We're joined today by our notable guests, Sue, Sandra, and Loretta. So hi, and a big warm welcome to you all. We'll hopefully get round to introducing each of our speakers individually just before they speak. But today on the topic of BME women, that is of course Black, Asian, and minority ethnic group women. But perhaps I think it's important to look at the topic as a discussion as a whole, and the issues around, the disproportionate impact of COVID-19 on the BME community at large, and then perhaps, at BME women in particular, because it's a particular nuance, I think here in the UK and of course other places around the world. And especially the topic of how a global pandemic has such a great and unequal impact within our society that we live in. And it's illustrated in both, the devastating and fatal health impacts of the reality. So I'm looking forward to tonight's discussion with our prestigious guests who will be presenting their views and expert opinions on the issue, through touching upon the socio-economical and psychological impacts, of course, alongside the worsening health crisis, through the lens of structural inequalities and systemic racism too. So without further ado, I'd like to pass on to our panelists, who each have 10 minutes each to present, followed by a joint discussion, amongst ourselves, as well as with comments and questions that we may have coming on from our live audience via YouTube. So please do feel free to comment and participate in the discussion. So thank you very much. First of all, I'd like to pass on to our first speaker, Sue Liburd, MBE, DL, Non-Executive Director of the NHS Clinical Commissioning Group. Thank you, Sue, for being here with us today. And if you're ready, feel free to go ahead.
Well, thank you for having me. I think we are living, obviously, in very interesting times. The COVID-19 pandemic, I think, offers us an opportunity for significant and sustained change. There's a window of opportunity right now, and that, I think, is because the world is awake, it's listening, and we're all trying to figure out what we actually can do. So let me just look through two particular lenses at the moment in terms of the current state of play as I see them. And I'll look at just briefly economic impact, and I'll look at some of the health impact, and hopefully not cross over in terms of anything that our other speakers, our other panel members are going to be sharing. So when we look economically, what we found is that women, as we know, tend to work in lower paid roles and in lower paid sectors. So we have a double whammy there. We're working in lower paid roles and lower paid sectors in comparison with men. So we're finding ourselves in health and social care, we're finding ourselves in education, we're finding ourselves in retail work, all absolutely essential work, but they have a tendency to be lower paid. As women, we earn less than our men colleagues, our male colleagues, over the course of a lifetime. So as a consequence, we're putting less into retirement pots, and we're putting less into saving pots. We know there's a gender pay gap, and that gender pay gap is in favour of men. We have legislation in place, we have gender pay gap reporting in place for organisations of a certain size. And yet we still find that in the UK, men are paid more than women within every economic sector, according to the Government Equalities Office. And for me, what is slightly disconcerting is even in low paid sectors, men are still paid more than women. So that's something that we all need to be looking at, and maybe we can talk about some of the things that can be done with regards to that. So as a consequence, this is, as I'm saying, it leads to a pay gap, it leads to a savings gap, it leads to a pension gap. And in the first year of retirement, men are projected to be in receipt of 25% higher incomes than women. 25%, I think that's significant. And that's in part because the decisions we make as women have a cumulative impact. The ripples run, and they run for years. So we add COVID-19 to the mix, And I think I could almost be confident in saying that the ripples are likely to impact women significantly up the line if we don't take some action now, not wait, because the pandemic isn't disappearing anytime soon. So those are some of the economic factors I think that we should be looking at. Secondly, as we look through the lens of the health impact, we know that people from our communities, from ethnic minorities, are more likely to have underlying health conditions that make us more vulnerable to the virus. That's one factor. Second thing is we work in roles where we've got greater exposure to the virus. For example, with high percentages, as I said, healthcare workers, frontline workers, public transport drivers, cleaners, carers. So this is where we're finding individuals being greater exposed to the virus. We also live in conditions as minorities which increase the likelihood of the virus spreading. We have, for example, greater community and a larger amount of intergenerational living than some of our white counterparts. So we know we encounter greater workplace inequality, housing inequality, social inequality, economic inequality, and you start to add all of those, and the evidence obviously points very, very strongly as a result of structural barriers and systemic discrimination that's faced by us, that we are going to be disproportionately affected. So, I'm sure some of the people, that are watching us this evening and going to participate in our discussion are going, well, so what? So we know some of that. But I firmly believe, as I was saying at the outset, is that COVID-19 times offers us an opportunity for sustained change. I think there's a window of opportunity because, as I said, the world's awake, it's listening, it's trying to figure it out. And we have our part to play as well. It's not about us sitting back and being victims. It's a time for us, I think, to be far more courageous. And I want to explore in this discussion some of those things that we can be doing. So those of us that are in work, we can be talking about things like, recruitment processes. We can talk about access to training and development, access to greater opportunity, participation within the workplace, finding our voice, using those different channels. So those are some of the things hopefully we can talk about as we go forward this evening. So we can explore some of these solutions more fully, obviously, once I've heard from some of my panel colleagues. All right.
Thank you very much, Sue, for highlighting, and I think it was a twist for me when you said opportunity. I kind of froze and thought, how are we going to see an opportunity through it? But I think the awakening that you mentioned, that and I think with the pandemic, and also perhaps the Black Lives Matter movement as well going happening in the same process, you see a wider awakening in society, and mentioning the gendered lens as well. Perhaps adds to that. So thank you very much. And if our other panelists have anything to add, please do feel free to ask questions and engage both after the individual speeches and also at the end. But yeah, I think you mentioned some of the long-term things, perhaps looking at the recruitment processes and training opportunities. But even in the short term, ensuring that PPE is available for those who are in greater exposed work environments is also crucial. Anyway, we're on to our second speaker at the moment, Sandra Kerr, OBE, or the Race Equality Director, Business and Community Organisation. Sandra, thank you for being here with us tonight.
Thank you. Really great. So thank you for the invitation. I'm glad that I can be here. So just want to set out what I have been doing. So just a bit business in the community. We work with employers, so public and private sector. So we work with policy making departments as well, who want to look at race equality and be the best in class, who recognize that something needs to be done. One of the first things we did, so the pandemic hit, is put out a fact sheet, which we call ethnicity. I called it ethnicity and the economic impact of COVID-19, because as soon as I heard the media saying there was going to be economic impact, I know based on 2008, when we had that economic crash, In 2010, 60% of ethnic minority people had no savings at all. And that's because of being at lower levels in organizations, higher housing costs, and all the kind of additional challenges that come with if you're doing shift work or 0 hours contracts. And we know all of these things. There is a known occupational segregation that Sue talked about, but also even sometimes within organizations, you can end up in the, you know, the lower paid roles. So we know from historic information, and also when organizations, the last financial crash was so sudden, they just kind of, you know, got rid of people without thinking. What happened in the end was Black, Asian women, you know, all the kind of specifics, protected characteristics, but particularly women, as well as ethnic minority women, ended up unemployed. And what it is well documented with DWP is when that happens, it actually takes longer to get back into a job, because we know through the mystery shopping that has been done, that if your name sounds like it's from Muslim or African sounding name, you have to put in more applications. So we know that there are market place challenges on that. And what I did was the fact sheet to really ask employers to think. The furlough scheme, things like that, gave them a chance to really think about what they are doing when they're changing the face of their workforces, who goes on furlough. Monitor that, look at that, because I really wanted employers to pay attention and be thoughtful about this, and also not make sweeping changes that might sound like a good idea. So an employer could say, oh, I think everyone should just take a 10% pay cut or a 20% pay cut, which might be okay for some people. If your husband happens to earn 50 times more than you, and that's no problem. But for many women, that is not the case. So really want them to be a lot more thoughtful about those decisions, and also to actively monitor what happened, who goes on furlough, or potentially if they downsize, to monitor so that we don't have a disproportionate impact on BAME women and women in general. And then the second fact sheet I put out quite quickly after that was called BAME Women, Mental Health and COVID-19. And that was because I know that there was data that surfaced in 2017 that said in any 1 week, I think 29% of Black women would report a common mental health disorder. And that means anxiety, depression, whatever. And when I scrutinized the data further, it wasn't much better for women from mixed groups and different ethnicity groups. So if you think, and that data actually originated from 2014. So if you think about that, 1 in 3, almost 1 in 3 women in any 1 week, because of all the things that Sue's already set out and we've already kind of heard in the introduction, because of all of these things under the surface, more likely to have feelings of anxiety and mental health challenges. And does anybody remember there being a big campaign to improve women's mental health or BAME women's mental health? No, so that means that was already there. And then the pandemic came. So we put the fact sheet again out to employers to say, think about the support that's available. Ensure, for example, where people may, if you've got any employees where English is their second language, please make sure that you do that provide that additional support to ensure that you're aware, that they're aware of where the services are, where the resources are, if there's funding, extra help, that they know how to get that, and encourage your managers to help them if necessary to fill out all the necessary forms. So really encouraging employers to be aware that because of the challenges of the pandemic, people's lived experience, and if they're in a small accommodation and they're partnered with somebody who works maybe in one of the health services or frontline services, that provides greater risk and greater anxiety. So really trying to help employers to understand that the lived experience is different and they must check in. And as part of that, I'd spoken to ONS and asked them to start to monitor what was happening on contagions and deaths. And thankfully they did, because we started to see that there was a disproportionate impact. And then we had COVID-19. So then we had the killing of George Floyd. So that was enough. And then we had that happen, and people have seen that stream into their homes. They've seen, their children have seen this at a time when school is not on. And that's another dimension, talking about mothers who have had to manage children without the education system, who maybe don't have the technology even to switch on if there is an online classes where they were available, and all of the challenges of parents trying to school their children at home. So that's one big, huge piece. But then also with that, parents having to kind of support their children to talk through some of the issues that happened with George Floyd and not quite knowing how to handle that. And I really think the UK need to examine that piece, because I think there's going to be a lot of mental health support that's going to be needed. I put a blog out to companies and to the government, to anybody who would read it, to tell them to look at 3 big things. One is leadership. So the importance of having voices at those top tables who can tell people the disproportionate impact in advance. Or, for example, if you think of what happened in the US, if there were Black leaders around that table with Trump, Trump who he respected and listened to, they would have told him straight away, you need to move urgently, rather than this prolonged dragging out of finally arresting the officers involved. And we in the UK know we have the Windrush scandal. If you had Black people at the top of the Home Office tables, they would have said, no, you've got the wrong people. So that voice at the top table and stakeholders, and I would say BAME Women even more importantly, when I was doing the fact sheet, I couldn't even find comprehensive data on Black women or Pakistani women or Bangladeshi women or Indian women, because we know the lived experience is different and you need the data to help you inform that. So in that fact sheet, I've called on government to start to capture the data in a way that enables them to really scrutinize some of the challenges and support employers in the right way. The second area, so one was leadership, the second one was allyship. So that's really calling on, we saw on our screens, white people out there as well as Black people saying, Black Lives Matter, let's do something. So really, how can we ensure that that is not a moment in time, but that momentum is built on? So some advice around that. And then the third area was around employees and communities. So this is about how can, what infrastructure can government, what lever can they pull to support enterprise? So people who maybe want to start their own business or do something at home, an online thing, you're skilled. And I think that's a potential area where BAME Women can maybe actually really start to thrive if the networks of support is there to help them understand how to really make the most of it. And that's something you could actually potentially work from home. So have the flexibility to look after your family, but at the same time be, creating some income. So I'm going to pause there, but thank you very much.
Thank you very much, Sandra, for all that. I mean, I enjoyed, the first comparisons that you made, to the 2008 crisis and the crisis that we're facing at the moment. And I think it's always beneficial to look at history and then to see that, in 2 years' time, 60% of the BAME communities, had no savings. I think that it itself is shocking. And now we're having, we just come out of a lockdown, and then there's talk of another lockdown, and this, is inevitably leading to increased unemployment and devastation for communities. This could be worse in economic times than the 2008 crisis. So thank you. I think that's a lot for us to dwell on and discuss in terms of what could be done, both in the work that you've mentioned, with informing employers and policymakers, but also, on perhaps on local council levels too, and within communities at large. So thank you very much. We're on to our last speaker of the panel, but last and not least, of course, Loretta Sollars, Head of the Health Inequalities and Deputy Head Children, Young People and Families at Public Health England. Loretta, the screen is yours.
Thanks ever so much. Just bear with me whilst I see if I can get to share a slideshow with you to talk through. I just ask, can everybody see? There's a slide set come up now.
Yep, it's
okay. Good. So I'm going to talk to you about 2 reports that Public Health England has published over the last couple of months, which have absolute relevance to this issue. So the first of those was an analytical report looking at the data to see what we could tell in terms of differences in terms of risk of getting COVID in the first instance, and then the health outcomes for people across different communities. And I'll share with you some of the key sort of findings from that report. The second report was a stakeholder engagement exercise that attempted to understand the factors that affect specifically BAME communities and their experiences of COVID-19. And I'll share with you the key themes that came out of that report. So starting with the data report, first of all, and what you'll see on the screen here is that we've looked at the number of cases up until the point at which these reports were made. So this was up until 13th of May. And the number of cases are grouped by age and by sex. So as you see, males are in green and females in the kind of reddish colour on the right-hand side of each pillar. In younger age groups, there's it's slightly more women than men who are contracting the disease. But then as we move into the older age groups from 60 plus, the rate increases significantly. So older people are much more at risk, and it flips so that men are more at risk than women as we move into those older age groups. Next, we looked at the data on cases and broke that down by deprivation. And what we found, unsurprisingly, was that for both men and women, those that lived in the most deprived areas of the country were more likely to have a higher rate of diagnosis of COVID-19. And that's something, some of the causes have already been mentioned by some of the previous speakers. We did split things across geography as well. So the greatest rates at that time were in London, the West Midlands, which reflected the way the disease had spread. And I think the fact that, again, London and West Midlands, you've got much stronger urban communities there. So the disease was spreading much easier in urban communities where people are living closer to each other than, say, places like the Southwest, where there's much more rural area. Okay, so the next slide gives you a summary of the findings in terms of ethnicity. And these findings here are of not the number of cases, but of the risk of death. So it's looking at the number of deaths broken down by different ethnic groups. And what we found with that is people who have Bangladeshi ethnicity have got something like twice the risk of death compared to people with white British ethnicity. And then those from Chinese, Indian, Pakistani, other Asian, Caribbean and other Black ethnicity backgrounds had something between 10 and 50% higher risk of death, again, when compared to white British groups. And then finally, people from Black Caribbean ethnicity have got something like approximately a 10% higher risk compared to white groups. So as you can see from the data, significantly greater risk if you're from a BAME community, particularly those in Bangladeshi communities. And again, just to emphasize, this is the analysis by death rather than cases, which will be slightly different in both situations. If we look then at those cases by ethnic groups, what we were able to do there was, again, to split it between male and female. So as you see, if you look at this, the first set of columns on the left-hand side, the split for white groups is pretty even. But when you then look at Black, British, Asian, mixed ethnic and other groups, there's a slight differential between men and women, with men having a slightly higher rate of cases. The reason why there's such a big column on the right hand side of other groups is because the data sets that we use to collect cases didn't give such a greater breakdown as the death outcome data that we were able to access. So those were the sort of data, what it told us at the end of May, beginning of June. And at the same time as we were collecting and analysing that information, Professor Kevin Fenton, Regional Director for Public Health in London at Public Health England, conducted a series of stakeholder sessions, 17 in total, that were grouped by different thematic groups, and something like 4,000 people participated in those sessions. And from that, we've pulled out what were the sort of major themes that came from that stakeholder engagement. So people from BAME communities and organisations telling us what the things that they thought were the causes of these higher rates and what were the things that could be done about it to address some of these issues. If you look at the top row, as has already been mentioned, one thing that was really emphasised was that the impact of COVID is coming on top of a much greater health inequality that BAME communities are already living within. Whether that's because of their social and living conditions, because of poverty, or because for health reasons they have more vulnerable groups, higher rates of respiratory disease. So these were long-standing factors before COVID came along to add to that health inequality. The second consideration, again, that's been mentioned by the two previous speakers, is around that increased risk of exposure. So BAME people are much more likely to be in frontline roles. They're much more likely to be using public transport, to live in multiple occupancy houses with mixed generations. And one of the conclusions in terms of how do we deal with that is to make much better, take much better risk assessments from a workforce perspective, but to understand the risk for individuals to having COVID-19. And again, as the data showed from the data report, there's a much greater risk of complications. Part of that seems to have been caused by BAME communities not presenting with their symptoms as soon as white community groups would, once they start to get symptoms. So they're leaving it till they're suffering much worse from COVID before going in and asking for treatment, whether that's through A&E or through contacting the doctor. And that's been compounded by the having, in the first instance, multiple long-term conditions. And these obviously are going to get greater as you get older. And again, as previous speakers were mentioning, mental health is a factor in all of this that I think is something that health professionals are dealing with now as people are starting to recover from COVID, and is going to have a long-term impact on our health generally, not just now, but in future years as we move out of and recover from the pandemic, and the impact of the pandemic economically as much as the health impact of it. And of course, if I look at the next row of factors, racism, discrimination, fear and trust. So a lack of cultural competence in the first instance in knowing how, what forms of communication and communication channels are Black people most likely to respond to that they use. They don't. Not all Black community groups will be using the mainstream media channels. They'll be using their own community channels. They'll need communications in their own languages. There wasn't as much translation done of the initial guidance and so on. Access to PPE, obviously a big issue for those essential workers. All of that building to a stigmatization and fear of COVID, late presentation to services, as I've mentioned, and that the role of the media is something that can most definitely be addressed as we look to the future. So moving forward, there was very much a demand from those that participated in the stakeholder sessions for a cross-government approach, to act now, not wait for more countless inquiries into this. And there were plenty of examples of things that could be done now, about improving ethnicity and faith data collection, and this distinction there that I haven't mentioned between ethnicity and faith in terms of the data and understanding the impact of the two. Obviously a need for further research to understand more about the impact and also about what can be done. And finally, a really big emphasis from those stakeholders that engaged in this research to really use community assets to work and co-produce, to engage, not tokenistically, in a really meaningful way, with those community groups that fed into this research, and will already be working at a local level to help support resilience responses. So those are the key themes that came out of the engagement sessions. They resulted in 7 recommendations that I should have included a slide on, but haven't, but are being picked up. And at that point, I'm going to stop and back to Iysha to lead us through a conversation.
Thank you very much, Loretta, for illustrating the engagement sessions that you mentioned and the 2 reports. I think we all found it very informative and necessary at that, especially looking at the urban areas, which actually is where most immigrant communities do also live because of the work opportunities. So we have BAME communities in those urban communities, mixed in with the poverty and, as you said, mixed generational living, and the various others. Things that are going to come out of the pandemic once we make our way through, as increased mental health recovery services that we're going to need as well. So it was a lot of points have been discussed by all 3 of our speakers now. I'm just going to look over the questions that we've got. I think the first one's very interesting. It's one that we've all touched upon, and that many reports argue that there are existing inequalities, which are the root cause of the current disproportions with COVID. And the question is, how would you summarize these existing inequalities in the context of COVID-19 pandemic? So, and then what can be done to reform these in particular? So I think maybe if each of us wanted to take an existing inequality and then perhaps provide some sort of suggestion on reform. So if anyone would like to go ahead, go ahead.
I'm happy to go first. If we look at, let's say, workplace inequality, let me use the NHS as an example. The NHS employs, in excess of 1.7 million people. And so we're, one of the UK's biggest employers. We are the most, I would argue, we're certainly one of the most culturally diverse organisations in the UK. And yet we suffer from what's called snowy white peaks. A propensity for white colleagues, particularly white men, to be leading the NHS. And we have inequalities around, as I've mentioned, pay. We have inequalities in terms of opportunity. And yet a lot of the wisdom around best practice is already in place. There are standards, what we call the RES standards, the workplace and workforce race and ethnicity standards that sit within the NHS. So we've got measurement mechanism. We have specific development programs at different tiers for particular leadership and management. So some aimed at that are gender specific, some of that are race specific. So we have training opportunities, we have coaches, we have mentors. The NHS have taken this really, really seriously. We have policy in place, and yet we still have inequality. One of the facts I was looking at that came out of the King's Fund research was around the fact that, for example, when we look at Black and Asian doctors, NHS consultants in particular, what we find is that they are paid on average £10,000 less than their white counterparts. So we have all of these amazing things in place, all of the things that are considered to be best practice, and yet we still have some inequality. And I think there are some things that we can absolutely do. And it speaks to a point that Sandra made reference to, and that is allyship. The tendency is to look at initiatives to support the minority. It's all of our problem. And therefore, when we look at allyship, I think we are potentially got a game-changing strategy there. And it needs to be active allyship. So it's not enough to say, yes, I support this in terms of our white colleagues. It is the, what are you going to do about it? We also know that what gets measured in organisation gets done. So if we are serious about moving the dial, then we need some significant actions, and we need, you know, clear statement and commitment. We need some key actions that we're going to be measured against, and there must be a penalty for not achieving those. And I think a couple of those things could actually start to move the dial. My third, and I think, point also to pick up on something that Sandra was saying, as well as Loretta in one of her slides, is around inclusive leadership. Leadership evolves, and if we've got organisations that are operating on old leadership models, old leadership competencies, then they're going to be behind the curve. So inclusivity, I think, is the name of the game. Well, as I say, using the NHS as an example, we have diversity. What we don't have necessarily is inclusivity. So developing inclusivity as a competence, I think, is important. Cultural competence, cultural intelligence, I think, are new leadership competencies that are required if we're going to address some of the workplace inequality.
I'm happy. Great points made by Sue. I want to pick up on, so one of the things I'm actively working with government, both sides of the house, to really get ethnicity pay gap reporting implemented. I think there just needs to be a really, really robust need to be transparent on that, because, as I say, I talk about, this has just spotlighted some of the disparities. And I know through data that I've seen from ONS that even within ethnicity groups, there's a gender pay gap for every group. You know, the men are earning more all the time. So we'll need to spotlight that, but also where it's people doing the same work and, you know, same roles, there's no good reason. Really need to kind of look at that transparency. We are, I think the allyship piece, as I say, it's one of the areas we've called for action on and really kind of starting to support employers. It's a new area for race. I think it's been quite popular on other protected characteristics, but never really thought about with the race lens. But really now, because of what's happened since the protests and the real kind of just, I think when Sue was saying, you know, because people are sitting at home, they actually got a chance to pay attention, because usually we'd be horrified and then we'd run back to work. But this time people were at home and had to kind of look at what happened. And I'm absolutely, so I'm writing, as I say, at the moment, I've run the data from our big Race at Work survey around the Black responses so that I can do a report, which I'm going to come out with next month. And one of the areas that I have been scrutinizing is around inclusive leadership, but actually being active to ensure that team members, number one, feel like they belong and that they have voice. And I would say the missing piece for the NHS was not enough senior people around those top tables making the decisions who could spotlight quickly that, hold on a minute, we seem to be having a disproportionate impact here of people not feeling like we're all on the, you know, the COVID wards and everybody else is on the phones, you know, depending on ethnicity lines. There's a lot of that. I've heard calls, I've heard transcripts of calls and realized that leadership is really, really critical. People around the top table who are sensitized, aware, who can be a voice for those who potentially are feeling they can't speak up, they have fears. So I think it's not that people in the front line didn't have fears, many just didn't feel like they could talk to anybody who would actually listen and understand the perspective that they were coming from. So that's where, again, the allyship really needing to work on the conversation so that people can actually listen to understand rather than being skeptical and thinking, oh, you're just complaining and moaning and not realizing that, no, this is a lived experience. And I think that's what the killing of George Floyd did, is shock people into realizing that, oh my, this time there was a camera on, there wasn't, you couldn't say he was resisting arrest. He wasn't. No one was there to save him. There were others and they didn't. And all of these things is what I think has just triggered and shaken everybody up to say, no, we need to put a stop to this. So it's about how can we use that awareness really to actually get the voices, the different groups. And as I say, BAME women who are, I'm sorry, invisible, must be invisible to policymakers, because I couldn't find the robust type of data so you can look at women at, what does a Black African woman or Black Caribbean, you can't, it's just hard to find that, but it really does matter because we're all here. And if they really want to be able to, as I said initially, to support in the right way, you've got to understand the nuances and tap into that. And even, Loretta, you're talking about people not presenting early. And if their experience with the NHS or health is not very good, they're not going to run there either. So there's, again, something about the service that people get when they get there. So they're happy to go to the doctors or the hospital rather than think, I'm not going through that again, and I'll hang on as long as possible, rather than having to revisit that. So those points.
Thanks, Sue. Shall I follow on next?
Go ahead.
So from a health inequalities perspective, looking at this, I think there was the word crisis. There's a myth, I don't know if it's true or not, that in Chinese it means both danger and opportunity. And I think we're in exactly that situation, aren't we? And that opportunity to really make the case now for reducing health inequalities, we really must take this. Professor Marmot published his sort of 10-year on report just as the sort of COVID was kicking off as an issue. I think it would have been gone and forgotten about if it wasn't for the impact that COVID had. And that sort of timing with the Black Lives Matter protests as well really has emphasised, and I think everything's building and building to make this really very much front and mainstream for government and the public. So in terms of health inequalities, I think that at a local level, directors of public health based in local authorities absolutely are working really closely with communities and with the representatives from their communities and using local communication channels and very much delivering services that support their local community. I think at a national level, there's been, I would say probably over the last sort of month or so, a real commitment to do that in a way I haven't quite seen before. So I'm sure many of you will have seen the adverts that went with the launch of the Better Health campaign this week. And there was a lot of work done in developing that campaign with BAME community groups, with focus groups, to make sure that it really was targeted and would be responsive to BAME communities, because they were shown to be having a higher level of diagnosis and impact from COVID. And I think that will continue more in the future. I think the other thing I'd just mention by way of sort of good practice that can be spread further is that with my Children and Young People's hat on, had a little bit of involvement with the Rise Above campaign. So that's a social media campaign to support young people's mental health and well-being. It very much focuses on social media and on influences who are influential to young people, and doesn't go anywhere near mainstream TV or anything like that, but its reach is pretty phenomenal, and the material and content in it is very much, again, co-produced and developed really closely with a lot of input from young people. And I think we'll see much more of that happening for BAME communities, for young people, and segmenting so that we get much more responsive campaigning and interventions and support for different community groups in the future. And I think that long term will help to reduce those health inequalities.
Thank you very much, both, to all three of you, for I think that the mentioning of leadership, allyship, and the diversity in campaigns and having a more nuanced and more specialist focus. The next question kind of I think is kind of leading on from that. So what we've been talking about is perhaps a long-term change. What can be done in the immediate short term to prevent BAME women from being impacted by the possible waves that are to come. I mean, there's talk of I think last month it was around December, and today it was mentioned that perhaps in September we're going to have the second wave. And what can we do in this month or a couple month period that we've got to help protect, the BAME communities? Anyone who feels that they can help? Go. Yeah.
I think we need to, what I call, fear less and be a little bit more courageous. We have a tendency as women, it feels a bit of a generalization, but in the work around women, particularly in the workplaces, we have a tendency to sit back, work hard, and hope that we get noticed in terms of our efforts. And there are we talk about imposter syndrome, so we get into positions, the next promotion wherever we are in an organizational hierarchy, and we don't necessarily feel that we belong. I think some of the things we can do immediately is find mechanisms to have our voice heard. So if we are part of networks working in the workplace, leverage the power of the network. I think in terms of our line managers, in terms of our colleagues, in terms of our allies, find our voice and start to ask. And ask the questions that sometimes people are a little bit frightened to ask. So if it's about pay, am I being paid the same as you? How many times did it take you to get this promotion? If there is an opportunity that we want to raise our hand for, then do we need some support to get just to the table? I just think it's about us in the short term having the courage, fearing a little less, being fearless, being a little bit more courageous and starting to ask our colleagues, because people are a lot more awake, as we've said, and people are looking within the workplace to find solutions. And I just think it's our opportunity. If we just sit back and wait, I think we're going to miss this window this time.
Thank you.
Okay, so I mean, I would have to echo one of the things. I think what Sue said is this speaking up. So interestingly, I mean, my role is to speak up, but I find myself, encouraging other colleagues now to speak up, and things maybe that I have overlooked or just let go. Now I'm like, no, I need to speak up, because I really feel there's a responsibility where there are blind spots if I see them operating, to speak up. But I would also encourage, because, and I agree, people are listening, and it's that element of don't kind of wait, because sometimes we wait to be noticed or to be called on, or for it to be our turn. If we see something going on in the organization or opportunities, or we actually just want to explore, or we have a challenge. If you're in the workplace, you have a line manager, their job, and an HR team, their job is to actively ensure that the well-being of the workforce and that everybody's getting access to the support and help they need. It really does matter that you embrace that. But also, I think one of the things I'm again thinking, really that people need to think about is, are there any kind of opportunities in their lives to think about potentially creating other income streams, particularly if you are at home and you can't kind of move around, because, I'm encouraging employers to make sure they're doing risk assessments, because I know it's been quite confusing, and I'm going to reinforce these messages. Sometimes it's not clear. What do you mean? Because you've said we must stay at home, then you say we can go, but then if we go, we're going to crowd out the transport system. So what do we do? There's a lot of, is it safe to go out now? And it's about asking the questions to get clarity, so that you can feel confident, whatever your decision to do, whatever you decide to do. But I agree that we are working in an environment where people are listening a bit harder, trying to pause rather than just being dismissive of what people are saying, and really want to for it to be better for all of us. And we know, get informed as well, because I know, for example, it's actually worth 24 billion per annum to the UK economy if they really tackled all the disparities on pay. Everybody was paid the right amount, everyone was promoted to the right level, everyone was employed. It actually will benefit this economy. And if you think about, we're going for a downturn, so the more inclusive you are, the more you bring everybody with you, give everybody a chance to thrive and participate, the better for the whole country. So it's actually good for us all. And I think knowing those messages really help to strengthen you when you actually stand up and speak up, because you realize actually what, if they catch this vision, actually it's going to be good for us all.
And I'd reiterate that as well and say speak up, and specifically in terms of the next spike, the approach from government now is to very much managing things from a local level. So a couple of weeks ago, it was Leicester, where the greater lockdown measures were put in place. The last couple of days, we've been talking about Blackburn and a few other places where there's we're seeing through the number of cases an increase on a much more local level. So I'd say don't feel that you need to speak up in national fora like this event this afternoon. It's about speaking up through local community groups that you're involved with and saying what are your needs. For some people, it's really important that material is translated and guidance, but there's a difference between stuff that is translated locally and stuff that is officially translated on .gov.uk. Some people prefer one type and others prefer a more local type. And similarly, people with literacy issues will find it difficult to read anything, whatever language it is in. So speak up and say, actually, in our community, for those older generations, we need much more that is communicated verbally through local media, whether it's through local radio or through local faith groups or whatever. So speak up and say what your needs are so that then those needs can be responded to, and do that locally just as much as nationally.
Mm-hmm. Mm-hmm. I mean, just on that point, I think just to come back at you and because you've read the reports in detail, I was just wondering, do you know if faith communities, for example, are being incorporated into the process of this, like dissenting the information to the public? Because I think it could possibly be a good outlet for especially for
yes, that's very much something that is happening at a local level. So local authorities, directors of public health will be working through their local resilience forums with local community networks, and that will include both faith groups, ethnicity groups, local churches. They'll be working through all those and know who are the strong leaders within the community. And I think to a large extent they'll also be aware of sometimes when we talk about leaders in the community, it's the same leaders every time, but how do you get to the people beyond the leaders so that you're actually getting to all groups of all communities and not just those that have traditionally been there leading in official positions? So they'll be aware of those issues, absolutely, and be working at a local level.
Perfect. Just on to the last, it's more of a comment than question, and then perhaps we could just share our general views on the comment just before we wrap up. So it's some criticised the government for its reluctance to act on racial equality. More recently, David Isaac said, the outgoing chair of the Equality and Human Rights Commission, said that the ministers are dragging their feet on tackling racial inequality in the UK and needlessly commissioning further reviews. The time for more recommendations, in my view, is over. We know what needs to be done. Let's get on with it. Was said. What do you think? Do we know what needs to be done? Is it just the time to act and act fast, or should we be reviewing further?
Well, I'm happy to jump in here. I'm with David Isaacs. I'm like, can we implement urgently all the outstanding recommendations and all the reviews that already exist? Quickly, focus. So that's what I think we need to do. Implement everything that we already know, because comprehensive reviews have been done, all the evidence, all the data. Coronavirus has just spotlighted these even more. So I'm saying twin track approach, an approach of implementation, and then go and have a look at what else you want to look at. But actually to review again, I don't know what on earth you're reviewing. I think it's a case of can we just move this along? And I specifically have been actively involved in the McGregor-Smith review, which is about pay gap reporting. And I'm saying that doesn't need a review. We've already got the evidence. We've had a consultation. We've already talked to employers and tested methodologies. It doesn't need a review. It just needs implementing. And I'm sure there'd be other bits of other reviews, like Lammin review or Marmot review or Windrush review, where people are like, just move it. We don't want to do another review. So that would be my thought. I think I've said that multiple times, so you get my drift, really.
I'm chuckling because I agree. we don't need another review. In the commercial sector, one of the things is a real acknowledgement of the fast pace of change. The world is changing, it's changing very, very quickly. If we just keep doing review after review after review, by the time we do another review, guess what? It's going to come out with the same recommendations, or predominantly the same recommendations, maybe worded differently, but they'll be the same recommendations. So I'm a firm believer in, we've had enough reviews. If you want to do a review, fine, but don't stop the act of implementing. So let's start moving forward now, implement the existing recommendations, and whilst we're doing that, we're measuring, and we can reiterate and iterate and iterate, but this should be a dynamic process, not wait for another review, is my opinion.
And similarly, I'm not going to say much that's different. The BAME stakeholder reports, that was one of the key themes that came through in so many of the different stakeholder sessions, was not another review. You know what the issues are. These are them. Just get on and do something. And I think that what was very interesting as well was, as Professor Fenton relayed that, he very much relayed across this message of, don't wait for somebody up there who's important to tell you to get on and do things. That, I think, was just such a massive message to me around the Black Lives Matter protests, was that people just went out on the street and they really made the case. And similarly, I'm not urging you to go out and push down any statues about this tomorrow, but please go out there and get on, make that difference in your local community or through the organisation that you're involved in to deliver the stuff that we need to be done. That will keep the pressure on to government at a national level to do the bits that they need to do, because the stuff that does need to be done, whether it's data recording, whether it's more action specifically for BAME communities, specifically to support women in those communities. So yeah, very much in agreement with the other speakers this afternoon.
Well, I won't say anything extra, as I'm in agreement too. And I think with reviews, they never seem to end. You know, there's always an extension, or it's late, or it's delayed too. So you have to wait month after month, and promised deadlines never get met. So I think we know what needs to be done, and we've discussed some of those elements here today. And it's just up to those decision makers to act on the suggested reforms, I think. So Sue, Sandra, and Loretta, thank you ever so much for being here, and for the lively and vital contributions to the discussion. I hope those decisions do get implemented, and thank you to all our viewers. Please do, subscribe, like, share, comment, and help get the message out. So thank you, everyone, and then good evening. I hope you all enjoy your evening. Yeah, for another discussion another day. Hopefully. Thank you, everyone.
Thank you.
Bye.
Bye.
Yes, I think we're off live now. Thank you, everyone. Thank you for participating. Great.
Thank you.